Okay, so welcome again. Sorry to have to record the video because I've been also delayed and it's difficult to coordinate socially with the distance. It's connected to the first talk. So for this second presentation, I wanted to explain how we can teach AI and machine learning to medical students. And so the title From Machine Learning to Student Learning is taken from a paper that we actually wrote on this topic. And so to explain, the problem is that computational psychiatry has been increasingly attracting attention. So the fact that we use computational methods to do psychiatry is really in the air du temps, in the zeitgeist of the moment. But all those accounts of computational psychiatry are very different, and already teaching computational methods for students required to clarify a bit what we are talking about. So for instance, in the case of Vicky and colleagues, they see major trends. So two phases of computational psychiatry. On one side, a theory-driven that seek to predict based on explanation and strong hypothesis about how it's supposed to work. So in this theory-driven way, we can have biophysical models, we can have algorithmic models. So for instance, in reinforcement learning for decision-making. And on the data-driven, the other side, you are making prediction based on data and existing databases without any prior hypothesis. In our case, we even see a third culture of computational psychiatry on top of those two generative model and machine learning approach. So the theory-driven and data-driven are more like this virtuous cycle on the right, which is that the data has to come from somewhere. And the third culture is digital psychiatry and all the digital tools that connect computational psychiatry with the real world, and especially the dyad patient and clinician. Another thing that is complicated when you're teaching computational psychiatry is to make, on the other side, people that are more on the engineering and computer science side to teach what psychiatry is and what is the ecosystem. Because you can take the data and apply machine learning and AI technology, but it's far more complicated than just doing this kind of analysis. You need to take into account different aspects of psychiatry, from the subjective experience of the patient to the criteria and consensus among experts and the state of the art in the etiology and the nosology of the field. So all those different aspects also are carried by different actors with needs and lexical terms that are really specifics. So you have to teach that so that people are not lost when they are interacting with the psychiatric community. And so on the other side, on the clinical student side, well, what they see is a possibility to connect a gigantic amount of data on one side with tools that would help in the diagnostic, the prognostic, and the treatments. The easy way of answering this wish is more like the startup perspective. So say we got to put AI in this black box, not necessarily explaining that. Sorry. And our product gonna do the rest. But when you explain that to computer scientists or mathematicians, they tend to see this as a joke. Like I was making on Twitter this metaphor with this contemporary artist that was duct taping bananas in a contemporary art fair in Miami, and calling that contemporary art. For mathematicians and statisticians, machine learning is just advanced statistics, but it's still statistics. And so there's like all these hope and hypes that needs to be addressed so that students know what they are getting their hands on. And so in our paper, from machine learning to student learning, we delineate 3 levels of challenges. First, a clinical challenge with the need to know the good practices of AI and machine learning to use, evaluate, interpret, and explain results. So that's like, I would say, a bare minimum. But there is also a development level at the academic organizational level, that is to bring engineers, scientists, and physicians together in interdisciplinary networks. So that's something we are currently trying to do with the FRQS here in Quebec. So to have like this kind of bilingual community of AI and mental health. And these require to have curricula that are both in data science, biomedical engineering, and ethics and epistemology. And so you see the figure at the top that actually, even before you get to the artificial intelligence part, you need a foundation on epistemology, bioethics, to know also the underlying assumption behind those algorithms and behind artificial intelligence. And finally, there is a final level of development that is the collaborative level to promote horizontal organization without partitioning between medical and AI. So that's actually trying to not have silos, but create programs where both aspects are integrated. And that's challenging, of course, for many reasons. But we started already by creating a course with Michael Chassé, a clinician at the University of Montreal, coming from more epidemiology and intensive care. So Michael is a clinician with a lot of knowledge into mathematics, statistics, and informatics. And we created this course, Foundation of Computational Medicine at the University of Montreal, the first one in French to address this topic. And in this course, what we are doing is trying to cover theory and applications with this bilingual aspect in mind. So at the theoretical level, for grounding a bit the concept for the students with the history of quantitative medicine and how actually statistics is a pretty recent tool for medical practitioners, especially, for instance, in clinical trial. It's only in the 20th century that we had the first clinical trial with proper statistics. So it's pretty recent regarding the history of medicine. And then covering different key conceptual tools such as Bayesian statistics, complex systems and networks, inference and prediction, and how the question of reproducibility in biomedical research is so important, the concept of big data or massive data in medicine, and finally, how computational medicine and artificial intelligence are interrelated. And then we have experts from the field that come and explain concrete application of those theoretical concepts in different fields of medicine. So, of course, medical imaging and radiology, which is like one of the field where AI has been the most developed recently. Telemedicine and telehealth, which is quite contemporary with the COVID pandemics. Avatars and conversational agents. So you saw that also, for instance, for the therapy, the avatar therapy for schizophrenia, but you can even also have conversational agent to pre-screen participants and have avatars for training social skills in autism, for instance. Precision medicine and biomarkers. So how bioinformatics is more and more implicated in decision-making for precision medicine. And it's not only in oncology and cancer research, but it's coming also in psychiatry. And finally, quantified self and connected bodies. And as I say, like, for instance, with all the wearables and how this digital psychiatry and digital medicine is becoming a reality in daily life. So it's more like computational medicine in general, but it gives you a sense of how we try to create this curriculum. And so it's all about creating a literacy for the students. So like now, if we take, for instance, scikit-learn, which is a library in Python that is widely used for basic machine learning. When you start with a problem, depending on the different situation, you have a decision tree to which kind of method you're going to use, coming from very simple regression to a more advanced neural network algorithm. But if you go to statistics, classical statistics, and look at biomedical research, most of the studies actually rely on one type of test, which is like the group mean differences between case versus control. And so part of this training for the student is to make them aware, for instance, of the potential problems with this kind of simplification. So in the case of autism, for instance, we recently published a paper showing how for biomarker discoveries, statistically significance doesn't mean clinically significance, and how through a meta-analysis, even taking the best effect size that we can think of in autism research, which is like more like theory of mind, so more clinical and behavioral aspects. You have an effect size of 1, which in the end translate only to 16% of participants being above 2 standard deviation from the control population. And the other metrics, so more like biologically grounded biomarkers, are actually about 0.5, which translate to 7% only of patients above 2 standard deviation. And so we warn about the danger of rareifying those differences and make them even potentially the cause of marginalization of population with only 7% of people concerned and a sweeping generalization to the whole community afterwards. And so going beyond this group mean difference require different methods. I won't have the time to cover all of them, but you can think about, for instance, stratification in the panel B, normative model in panel C, and of course, there is also mixed models in the panel D. To show you just a couple of examples, I worked, for instance, in stratification based on genetic networks. So you take large cohort of highly heterogeneous genetic profiles for patients, you go back to the individual level, and you use machine learning to cluster patients based on homogeneous genetic profiles. And these allow ultimately to give information for clinical decision making, For instance, in the case of psychiatry, pharmacological response to drugs or response to cognitive behavioral therapy. So this precision psychiatry would require ultimately this kind of methods. But these more like discrete choices. If you need more continuous account, for instance, for assessment and staging and following the progress of developmental trajectory or patient trajectory, I've been working also on another method called normative modeling, where instead of having this kind of dichotomia, case versus control, here you try to describe in a continuous fashion the trajectory of patients. And this allows, for instance, in this case of with autism, to show that something that would have been a statistical difference between autistic patients and control would in fact been wrongly associated with autism diagnosis instead of having been caused by intellectual deficiency, for instance. So I spoke in my first presentation also about multiscale modeling, this part also of the things that students would require to be aware of, that we are now at the stage where we can model things at the molecular level, at the cellular level, but also at the individual level. And more than just modeling statistically, to have generative models, so being able to actually simulate what we are observing. And I will finish with two examples of other type of computational psychiatry, because people would think computational psychiatry is mostly centered on the brain and neuropsychiatry, but actually it's not necessarily bound to computational neuroscience for neuropsychiatric disorder. You can also think about symptoms networks. So for instance, here it's a study with my colleague Jean-Arthur Micouleau-Franchi, where we took data from the World Health Organization on the MINI to try to identify core symptoms in the general populations that are driven psychiatric disorder before their diagnosis. And this is another example, still with my colleague Jean-Arthur Micouleau-Franchi, but with Christophe Go as the first author, where we compared the representation of mental health and specifically autism on Twitter and on PubMed to confront and see in parallel what are the key topics for the community of patients and for the researcher. And we can see that those topics and interests are not necessarily aligned. So for instance, in the case of Twitter, the major topics that come up are about acceptance of autism, about mental health awareness, while on the PubMed biomedical research side, it's more about clinical neurophysiology and neurogenetics, neuropharmacology, and comorbidities. So maybe we should also use those computational methods beyond individuals to better inform psychiatry ecosystem, as I mentioned, that include also policymaker and patient association and so on. So thank you very much. Unfortunately, I won't be for the question there, so feel free to contact me by email or through Twitter. All my papers are in open access on my website. So thank you very much again for the invitation, and looking forward to interact with you all.